Limbal relaxing incisions have gained widespread acceptance among cataract surgeons, where it is often combined with the cataract operation to reduce pre-existing astigmatism. This results in better post-operative vision without glasses. However, freehand arcuate limbal cuts are difficult. Because it's difficult to cut on a curved surface, freehand cuts often result in uneven depth with poor control of the arc length and placement. Now there is a tool that eliminates the pitfalls of making paralimbal incisions by hand. Introducing the Terry Schanzlin Astigmatome, available exclusively through Oasis Medical. The Oasis Astigmatome enables a doctor to treat astigmatism quickly and easily in the office. The Oasis Astigmatome is superior to freehand cuts. It provides axis alignment, consistent incision depth, controlled incision length, and secure corneal centration. You can use the Oasis Astigmatome to reduce astigmatism during cataract surgery and in conjunction with LASIK surgery. Post-op correction of unwanted iatrogenic astigmatism, such as that induced by cataract surgery, astigmatism following corneal transplants or grafts, congenital astigmatism, and conversion of toric lens wearer to standard soft lens. The astigmatome has 4 components. The vacuum speculum provides fixation and lid separation. Fixation is achieved by a disposable spring-loaded vacuum syringe, which provides the required level of suction for secure fixation throughout the procedure. The vacuum speculum accommodates a range of interchangeable cutting templates to assure consistent predetermined arc lengths. A template of a given arc length is selected according to your preferred nomogram and surgical plan. Consistent depth and reproducibility are achieved with the disposable astigmatome blade. Preset blade depth options are available in double or single blade designs. During the procedure, the blade tip position is visualized by external location tabs, which also provide a rotational stop indicator when used with the astigmatome cutting templates. For safety purposes, a blade guard protects the blades until it's retracted when it is inserted into the aperture of the astigmatome cutting template. It is essential that pachymetry readings be taken and documented prior to surgery. A surgical worksheet is provided in the Astigmatome training manual to document pachymetry findings and other information. Pachymetry measurements are taken at 5 points, centrally, and 4 points 90 degrees apart at 8 millimeters. The 5 entry boxes permit the display of corneal thickness found at each location. The worksheet also emphasizes the need for plus cylinder notation to avoid treating the minus axis. Select a blade depth that is up to 100% the corneal thickness at the planned blade path. When using the corneal map in surgery, a standard for the 0-degree reference point should be defined. Orient the map to match the position of the patient on the table. The map is marked twice at the slit lamp. The patient should be in a sitting position. First, mark the map at the axis of the steepest meridian. Use the topography map to determine the axis of the plus cylinder. If the surgeon is positioned behind the patient's forehead looking at the patient's feet, invert the corneal map. Second, mark the planned path of the blades from start to finish. The blade path is based on your preferred nomogram. You may consult the nomogram provided by Oasis Medical or one of your own choosing. During surgery, the vacuum tubing is attached to the port on the barrel of the speculum. Position the astigmatome speculum so that the limbus is seen in all 4 notches. Be sure that no conjunctiva is trapped under the footplate. In accordance with the surgical plan, the appropriate astigmatome cutting template is placed into the vacuum alignment speculum and properly aligned. Match the alignment index marks on the speculum barrel and template to the previously placed scleral axis marks. The 0-degree cardinal indexing lines are aligned with the previously placed plus cylinder axis marks. Suction is attained by releasing the syringe piston and centration verified by observing the central corneal mark in the center of the template's aperture. Continue to maintain a dry cornea. An astigmatome blade of the correct blade depth and configuration is selected in accordance with the surgical plan. Insert the astigmatome blade into the aperture of the cutting template. The astigmatome blade indicators are placed at the starting point of the intended arc. Because the blades cut only in the clockwise direction, the blade position indicators are placed against the most counterclockwise walls of the template as the starting point. Rock the blades into the cornea to ensure full penetration. Centration is again verified by viewing the central corneal mark, visible within the astigmatome barrel. View the cornea to confirm that no aqueous is present, thus confirming that perforation has not occurred. Verify that both centration and vacuum have been maintained. You are now ready to place the cuts. Using a single sweeping motion, slowly rotate the astigmatome clockwise to the end point indicator of the cutting template. Consciously maintain equal pressure on both blades so the cuts are exactly alike by the end of the pass. This is best accomplished by using the arm and hand together in a smooth sweeping motion as opposed to simply rolling the astigmatome between the finger and thumb. The incisions may be inspected for depth and symmetry with a suitable instrument. A sterile preset groove blade may be used for enhancement depending upon keratometric findings. Vacuum is released and all instrumentation removed. The patient is allowed to blink. Following surgery, there is little discomfort for the patient and recovery is very quick. Most patients achieve normal vision within several hours. The eye does not need to be patched. The recommended patient postoperative regimen is fluoroquinolone once each waking hour and a mild corticosteroid 4 times a day. No ointments are used. At the 1-day postoperative visit, fluoroquinolone may be decreased to 4 times a day. At 1 week postoperatively, all medications are discontinued. At 4 weeks, the patient is refracted and the outcome is assessed.